Welcome to the Multiple Sclerosis Summit Series Part 1, presented by Northwestern University Feinberg School of Medicine at NeuroSeries Live. We are live in New York City. My name is Michael Ayala, and you are tuned into a session titled Disease-Modifying MS Therapies in Clinical Practice, Which Therapies for Which Patients, featuring Dr. Fred Lublin. Dr. Lublin is the Saunders Family Professor of Neurology and the Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at Mount Sinai Medical Center. Doctor, I want to thank you very much for joining us.
Happy to be here, Michael.
All right, we appreciate it. And before we get started, I would like to remind everyone that this is an interactive session. We will be taking questions in real time throughout the entire presentation. You can send your questions anytime during the program through the box in the lower left-hand side of your screen. I will monitor them here in the studio and pose them to Dr. Lublin when appropriate, and most likely at the end of the presentation. All right, without further ado, I would like to turn it over now to Dr. Lublin. Doctor?
Thank you. So multiple sclerosis has been at the forefront of the rather nascent field of neurotherapeutics, especially in the area of disease-modifying therapies, which still are uncommon in neurology. However, in multiple sclerosis, we now have 10 marketed agents that are disease-modifying therapies. They represent 7 different mechanisms of action, but all of these mechanisms of actions are anti-inflammatory. And I'll show you how that's helped us, but also how there's an opportunity for other mechanisms of actions to advance the field. So first, we have to think about, who do we treat? The studies that we've had that have provided the evidence for treatment decisions and for the regulatory approval of agents have been primarily in relapsing remitting patients. The approvals have said that these agents could be used in relapsing forms of MS, which means relapsing remitting, secondary progressive, progressive relapsing, and also the first episode of MS, which is called the clinically isolated syndrome, or CIS. The studies have been in relapsing remitting MS and in CIS, and both of them have shown that if you utilize these agents, you lessen the annualized relapse rate, you can lessen the MRI activity, and in some cases you can lessen the accrual of disability. Now, the CIS, the clinically isolated syndrome concept, came along a little later than the relapsing form concept. These are individuals who've had their first attack of an episode of what we think is inflammatory demyelination with consistent abnormalities on the MRI scan, but have not yet met the diagnostic criteria for multiple sclerosis. Nevertheless, we have, I think it's up to 5 studies now that show the various agents that are out there can alter the course of the disease when used very early. And this has become an important concept for us, and that is the earlier you treat, the better off patients will do. Now, I have an item here about looking at CIS versus McDonald. McDonald are the diagnostic criteria guidelines that we have recommended since 2001. The latest iteration of those guidelines, the 2010 version, have made it much simpler to diagnose multiple sclerosis. And they've even allowed for diagnosis with a single attack by using a surrogate for dissemination in time. And that is an MRI that shows lesions consistent with MS, that show both T2 lesions that are enhancing and non-enhancing, and also not the symptomatic lesion. Because of that, the number of individuals who have CIS versus confirmed MS has dropped, and it's dropped by about 50%, because about 50% of the individuals who present with their first attack will fulfill these new McDonald criteria. It's a matter of terminology. It doesn't really matter a great deal whether you call someone CIS with abnormalities on their MRI scan or McDonald MS. The therapies are pretty much the same. And then we have the rather intriguing but somewhat confusing concept of the radiologic isolated syndrome, or RIS. These are individuals who have an MRI scan done for some reason other than for inflammatory demyelination, but rather either for a headache or a head injury, and the MRI looks like MS. And you get the report back saying it looks like MS, but they've never had a neurologic event that's consistent with MS. And we know that some of these people, especially those that have gadolinium-enhancing lesions or fulfill McDonald criteria or have spinal cord lesions, are at pretty high risk for converting to MS, but we still don't know what to do with them when they're at the RIS stage, and we have no treatment guidelines in that group. Our most vexing issue is what to do about progressive disease. So these are individuals with secondary progressive MS or primary progressive MS or even progressive relapsing MS that are in the progressive phase and are progressing. And none of our therapies have been particularly successful in treating that group, and I'll come back to that a little later in the presentation. Now, McDonald has been important for us, for the field in general, for neurologists, because it leads to earlier diagnosis, and as I said, we have evidence that earlier diagnosis leads to earlier treatment. Earlier treatment has led to better outcomes. Despite the fact that it's easier to diagnose, and you can diagnose earlier, the sensitivity, specificity, and accuracy of these latest criteria are comparable or better than the prior diagnostic guidelines. Also, the way the new guidelines are laid out may reduce the need for repeating MRI scans in many cases. Now, there is a caution that's always been there when you're utilizing MRI in the diagnostic criteria, and that is one has to be very careful about interpreting the MRI scans. Be careful about non-specific white matter lesions. Be careful about venous angiomas, which may look like gadolinium-enhancing lesions. So that's the big caution here, that the MRI scan really should look like inflammatory demyelination. Now, what do we treat? Well, the mechanisms of worsening MS, when you look at them clinically, there's two ways individuals worsen. One is a stepwise accrual of deficits that occur from incomplete recovery from exacerbations in the relapsing form of the disease. And so with any given exacerbation, there is about a 50% chance of some sort of residual dysfunction, and maybe even higher depending on how carefully you look. But just from a clinical point of view, it's about 50%. And then those can build on each other stepwise and lead to accrual of disability. The second mechanism is the gradual progressive worsening independent of relapses that occurs in the progressive forms of MS. This is the form that leads to the most disability over time. Pathologically, we think we're dealing with both inflammatory disease and in the progressive phase, also neurodegeneration. As I mentioned earlier, the mechanism of action of our available therapies looks to be anti-inflammatory. It's not clear whether beyond turning off the inflammation, we can also affect the degenerative phase of the disease, and that's one of our goals for the future, and we'll come back to that. This rather busy slide highlights one of the issues we have, and that is to the far left, we have the initial episode, maybe even an initial MRI scan that's abnormal, but as I mentioned earlier, we don't know what to do with those. But with the first attack, with changes on the MRI, we have a pretty good idea that this person has inflammatory demyelination of the type of MS. What we don't know is who's going to go off to the far right of the slide over time and do just great, and we have lots of individuals who do that, and who's going to end up in the upper right corner with serious disability, loss of brain volume, atrophy, and all the other bad things that MS can